it's really interesting and a pleasure to be here to see how far the industry has actually advanced over the years. So my presentation today, we've had some just amazing presentations. I'm going to bring it down a little bit, and I'm going to talk a little more granular on some specific things that folks are doing. So when you have if you ever get offered a job that has global in the title, be wary, because it can be good or bad. I've been to about 40, I think it's 46 countries in a little over 4 years. So you get to see a lot of great trends and what's going on. And also I get to see that a lot in the US, right? A lot of the things that are going on. So I'm gonna bring it down a level and talk about some of the more practical things that we see organizations doing and how collaboration and how connectivity and interaction actually is helping healthcare organizations. Now, a couple interesting points to start out with. Polycom, we actually just did an assessment, an evaluation, and we got about 1,400 healthcare providers. About 50% of them were clinicians, 25 were administrators, and then the other were allied health. And we had a really good geographical dispersion around the world. And what was really interesting about that is, so when you think about technology and the kind of business that we're in, collaborative healthcare, so we asked a question, and I thought this was really interesting. We said, okay, number one is concerns about implementing collaborative healthcare and using this technology, right? And the reason we're here today and why Care Connection, everybody, the whole concept is that it's more efficient to move information than it is to move people, right? That's why we're here. And that's the whole promise of what this technology brings. But the question we asked them was under that basis was, are you more concerned about the technology? Are you more concerned about confidentiality? Or are you more concerned about the governments or the payers being able to align and allow you and incentivize appropriately for you to leverage these new technologies that are coming out? Okay, so which one do you think overwhelmingly got the most concern from healthcare professionals? The government, yeah. Yeah, it was about 80%. It was really interesting. People really weren't concerned about the technology. People actually felt like the technology was there. People felt good about that. The gentleman yesterday said, you know, we worry about our bank accounts, right? And we worry about you know, we worry about security, but we also worry about our bank accounts. But you know, I was in Colombia last week for work, and it didn't stop me from throwing my ATM in, and you know, my card being all over the place, right? So so those things are occurring on and on. But to take a step back as we look at that, let's sort of look at where we come from and sort of where healthcare reform meets collaborative healthcare. So I just didn't grab this. So I assume that's the right button. So I think the first thing was, this is actually from a McKinsey report. And the really interesting thing for me when I looked at this, so from 1960 to 2010, the cost of healthcare, and I know you've seen a ton of statistics the last couple of days, so I'm going to go through this fairly fast. But the cost of healthcare has actually increased 5 times what the gross domestic product did, right? Which is very interesting. But what's even more interesting is that, so healthcare is susceptible to market drivers that increase cost. But the part that was really interesting as you look at the next slide is that we totally did not change the way that we did business, right? We didn't do anything different. And I think the first thing when I looked at this slide, I was looking at productivity from 1990 to 2007, is that we actually decreased in productivity by 0.8% with a 3% increase in employment. But I was kind of like, man, real estate beat us. You know, how do you innovate in some of these other areas and increase productivity rather than healthcare? Now, why is this important? I think that we realize, as I've traveled around the world, met with a lot of different people, is that, you know, it really is reform and we're all incentive driven. And I appreciate what Joe said, you know, kind of about the money part. I think we're very naive if we don't look at our organizations and realize that the bottom line is that there's a bottom line and that we have to prove those things. And I'll talk about some of those basis, some of those foundational things. So the healthcare productivity is what changed it. Now, saying that, you've heard so much the last couple of days on what we need to do. Population-based health, you know, we need to do more better, you know, care management, you know, all of these other things. Now, what that means to me and what's important is we need more touch points, right? So what does that actually mean to the average person in the US? If you look at users, and they didn't have the 15 number, but I'm sure it's pretty close. If you actually look at the users, the penetration that actually have access to the internet in the United States is 86.75%, right? So that's pretty intensive, and that's very extensive, actually, when you look at it. So we have the touch points of a lot of the things that we've talked about that we can reach out and collaborate and provide better care coordination and all the other things that we talk about, which is very, very important. And then I get the question, they're like, okay, so you have that, and the important thing here is that they actually predicted a 7% year-over-year growth in this actual study. But the thing that comes up a lot is people always ask the question, they're like, well, 87% of Americans use the internet, but what about the actual group that we consider to be, developing more chronic disease, which is sort of the 50 to 64-year-olds, and actually 88% of them use it. And then on top of that, the next question is, what can we do with it? Like, organizations like Care Connection, what can we actually do with it? We have the ability. How many of you do video from your home, like use Skype or FaceTime and those sort of things, right? And it works, right? I mean, how many of you it doesn't work? It's pretty solid, right? Sometimes, right? Some people live in areas where that's just not a reality, but I think most of us do. So picture that same scenario. We can make those same connections and we can align. Now, why is this so important to us? And I think the key point is this, is we have increased touch points and we can actually manage and we can actually make a lot of these changes that we talk about. Now, the opportunity that this provides, as we just explained, the first thing is that this was by the Department of Labor, which I think is really an interesting statistic, is 25 to 54-year-olds with children, right? They spend about 77% of their time at work and at home, okay? How many of you in this room can get health care at work and at home? Right? I don't see one hand being raised, right? But how many of us can, and we keep talking about this, we keep saying this is the way things are going, but how many of us are actually do it? So there's where the opportunity is. Now, we've been on a fee-for-service basis. Everything's about fee-for-service. We get paid. We see doctors. We get paid. We kind of move on. Now, as those incentive models change, we move more towards capitated rates, right, where it's not just the doctor generating the revenue for the hospital by doing a procedure, where it's just as much about the actual care team on capitated rates where they get a certain lump of money every month to take care of this patient. We are going to see the incentives change and the more touch points, and we're going to have a different delivery models and different systems. And I think that's very, very important for us to know, and that the infrastructure is there to do it. So when we look at the applications, here's what I see. I meet with probably 3 to 5 hospitals a week, and then I'll dig a little bit more into the actual kind of nitty-gritty of what a lot of you are here for. But the key applications that we see, and organizations are still trying to figure out. They're saying, we know we need to do this, but if we're a payer provider, it makes sense because we pay the bill, but we also take care of the patient, so it makes sense for us to do it, right? But then you have another small hospital and says, we know we need to prepare for this. They want to decrease the 30-day readmissions because of the penalties, right, for Medicare patients under the Accountable Care Act. But there's kind of 4 key areas. One is wellness and prevention, right? So we need to educate. And I see the gentleman from IBM Watson's, which is here. So it's interesting when you look at wellness and prevention. We'll talk a little bit more about that, the area that people are focusing on, and it's not as short-term as you might think. We're seeing some different sort of mind shifts. The next one is care coordination. There's a study, and I've actually looked at this a couple times, that says that 30% of the $3 trillion that we spend in healthcare is wasted, okay? And this study, it was by the NIH, basically said that 20% of that is from a lack of collaboration and communication. So we're duplicating tests, we're not talking, we're not integrating, and it's causing, we have medication errors on discharge because doctors don't even talk to each other. So collaboration is a big, big point. Remote monitoring. Remote monitoring is in a few different phases. Are any of you actually doing remote monitoring for post-acute discharge, like CHF patients, COPD patients, anything like that with biometric data? Is anyone doing that? I got one back here. Okay, great. And it was interesting. Someone said yesterday that the statistics were there wasn't a lot of benefit on some of that from a cost perspective, but all the data that I've looked at actually has shown some significant reductions in rehospitalizations, and it can be 60 to 80%. And when I actually so I started out as a nurse, and I made my way up to executive director of the main telehealth network. We had about 350 sites, and we actually supported home health organizations. we actually did a study, and we actually found, even back in the day, this is before when we would just use dial-up modems, that we actually were able to reduce rehospitalizations by 60 to 80% because we would be flagged. Patient gained a kilo overnight, their O2 sats were 88%, you call them. The difference is then we didn't have video and stuff to react quickly. We had to get in the car and drive 2 hours to be out there to help them. So remote monitoring to basically stop that post-discharge readmissions and unnecessary readmissions, which, a few years ago, the statistic was $25 billion. And then telehealth. Now, we've heard a lot about this. So when you think of telehealth, I kind of see it in 3 different areas. First of all, the term telehealth means a lot of different things, right? It means a lot of different things to a lot of different people. There was a really interesting statistic. So in 2015, there were about, according to a study by Tractica, there were about 15.8 million telehealth encounters. And the majority of those, depending on what, like I said, and these were video encounters, okay, video telehealth encounters. And the majority of those were clinical in nature, okay? By the year 2020, they predict there's going to be 158.9 million video telehealth encounters, again, using that broad term telehealth. And the majority of them are going to be non-clinical in nature. It's going to be about the care coordination. It's going to be about wellness and prevention to change behaviors. It's going to be about these other things. So what I'm seeing out there and what the market is seeing, as incentives and reimbursement change, delivery models are too. So collaborative healthcare. This is really about how do we reach across sort of the catchment area of the organizations that we provide care to, and even reach, of course, as we've talked about, into the home. And how do we do it for multiple applications? An interesting fact, though, I show this kind of like, picture a big hospital in the middle. Those things don't exist anymore, right? I mean, people have heard of specific companies out there. Any of us can get online and my company, we use United Healthcare, and United Healthcare actually reimburses for in-home telemedicine visits for 20 million people, and I can get on and I can get a doctor and I can be doing video online with a doctor, right? So healthcare doesn't really have geography like it did before, and kind of to Joe's point, when you look at the drivers of healthcare and the business side of it, this is a big concern in an industry where it's a business, and it's a revenue-based business. So if you look at that, Medicare does reimburse, right? So Medicare reimburses, but they have specific criteria. It has to be a live video interaction, right? The patient has to be physically located in a healthcare facility, so in a hospital, a skilled nursing facility, an outpatient mental facility, a critical care access hospital, and then there has to be specific, and there's some other ones too. And then there's some, like a federally qualified health center, a clinic, a physician's office. And then there has to be a specific presenter, or a specific physician that's actually seeing them. It has to be a physician, a mid-level, such as a nurse practitioner, a physician's assistant, and psychologist, LCSW. So Medicare does reimburse, but there are the stipulations. The patient has to be physically located in a non-metropolitan statistical area, so basically rural, or in a HPSA, health provider shortage area. They actually have to be physically located in one of those buildings, and it has to be a live interaction. Doesn't matter where the doctor's located, as long as they have the licensure, the license that they need, or credential and privilege, and if it's in a hospital. Medicaid, right? Medicaid. Unless something's changed last time I looked, but all but 2 states actually reimburse for telemedicine in some form or fashion or another, right, with Medicaid. But those are state decisions, and you have to look at that and decide. The good thing is, though, there are actually 28 states that actually have laws, basically legislative mandates, that you have to reimburse if you're Medicaid or if you're a private payer in there, and some of those are parity laws where you basically have to provide the same level of service, right? So that covers a lot of the Medicaids, and then it also covers a lot of the privates within those states, but then you have some variations from there on the outside. So that's very, very important. So yes, it is reimbursed when you look at your business case. Now, what's interesting about telehealth, I always think of 3 things when I actually look at institutional telemedicine. And I used to do consulting, and every time I get in front of a group, as you kind of go through the chain of who you're going to talk to when you're implementing these programs, I think there's really 3 things we have to prove, right? First of all, who are we here to take care of? The patient, right? So whatever application you're going to look at, if it's mental health, if it's telestroke, there's some good data out there, and we've been collecting this for years, that shows that patient satisfaction is actually very high. right? It's usually over 90th percentile. People like telemedicine. It's kind of the version that I'm showing on the screen now. The second thing that we have to be able to prove, and you'll get challenged on it a lot, in some areas we have the data we need, in some areas we're still struggling a little bit, is clinical efficacy. The gold standard, and what I try to say, is how well can I provide care from a distance and provide the same level of care as if the patient was in the same room with the clinician, right? That's kind of the gold standard of care. And there are some good studies out there. I think, Joe's in a different role now, but he could talk about, telestroke, and there's some other good studies from universities that actually show this. Mental health, there's some great comparison studies that actually shows we can really provide effective care, right? And clinicians are gonna wanna see that. And then, of course, the third thing, what does everything always come down to, unfortunately? Cost, yeah, money, right? It comes down to the money. And just all my experiences of that, be ready to prove, how can we increase revenue or how can we decrease cost, right? Which is very, very important. And have those things ready, because I guarantee as you implement your program, you're gonna be challenged along the way with each of those different things, and no matter what you do, okay? Now, as far as technology goes and innovation, I think sometimes people think it's just like a video call. There's different kinds of telehealth. I'm gonna talk about the home environment, but telemedicine now has become very advanced, where doctors can be anywhere. If it's institutionalized, like this technology, you can integrate into electronic health record. You can take images and put them in PACS systems. You can do all these different things that we weren't able to do before, right? And then even more, I think what's more, what is telehealth about in telemedicine? It's about breaking down geographic barriers and look at the reality. And we all know the issues we're having with electronic health records talking to each other. So think about that when you have sort of a large geographical region, and this big center is using Epic, this one out here is using Allscripts. How do we bring them together? So we're actually seeing a lot of vendors out there that actually have software that is made specifically to tie all of these things together for scheduling and referrals for telehealth. So it sort of closes that gap and allows that connectivity from an HL7 and a scheduling perspective moving forward. So key telemedicine applications. Any guesses? I mean, this is sort of an anecdotal thing, or unless someone has seen some data I haven't, but just from my experiences of traveling all over the place. Any guesses on the most utilized or most popular application right now using telehealth, like I explained, that live interaction between a clinician and a doctor, and it being inside of an institution? Any guesses? Pardon me? Derm's up there, but it's definitely not the biggest one. Telestroke is big, right? Telestroke, I'd say there's more project. There's tons of programs out there going on, and again, Joe could speak to this because that's what he did for years. But what we find is, they're very. There's a lot of programs, but of course, thank goodness, right? There's only a low percentage of people that actually have stroke. So a lot of times, so the numbers as far as utilization, but one of the biggest that we continue to see, telestroke continues to grow, mental health, and then of course ICU, right? EICUs continue to grow substantially, as the gentleman talked about earlier. But we're seeing more and more of primary care, and we're seeing a lot of this actually is sort of in urgent care clinics. There are some very large urgent care clinics that say, hey, you know what, I have 10 patients waiting in this one, and 100 miles up the road, I don't have any patients waiting. How do I load balance? How do I better utilize my resources? And they have like this air traffic control technology that actually connects them to other sites. So that's another big area we're seeing growth in, and then all the other ones. Consumer-driven patient trends, and I got a good example. There's this great company called Care Connection, and they actually, so they can do this stuff, right? So it's pretty cool. Now, what are some of the benefits of it? How many of you are actually doing this and actually connecting to, how many of you actually have been at home and seen a doctor on your mobile device or on your computer while you're in your own home? Has anyone done that yet? Okay, I see one hand back there, a few people. What did you folks think? Good, bad? You love it. Okay, great. That's great. There was a study done that said about 57% of people said that they would do that. They would do that. Of course, that was done by the study was done by one of the companies. So consumer-driven trends that actually decrease, and we're seeing sort of an interesting shift in the market. Because if you remember, there were some companies out there that would just do this, right? They were like private organizations. You get online, you swipe your credit card, you pay your $50. You get on there, you get a doctor, you're talking to a doc or a nurse. And then they'd basically see you. But a lot of people had some issues with that because they're like, the patient's paying $50. There's a lot of pressure on the doctor to do something. And what if they need objective data, right? In healthcare, there's subjective and objective data. What if I'm saying, man, I have a nasty sore throat, and you can't do a throat swab, right? What if you have the symptoms of a urinary tract infection? There was a study done on that basically said that if someone goes to the doctor with a set of symptoms that seem like a urinary tract infection, they get antibiotics about 48% of the time. With this other model of just kind of connecting in without referrals and without sort of follow-up and those things in place, what percentage of the time do you think people got antibiotics? Any guesses? Just throw a number out. It's really high. 98% of the time. They actually got antibiotics. So some of the things that you're seeing to address this in consumer-driven models, and this is very big. First of all, healthcare systems, they don't want people coming in and taking their patients. That's number one, right? So a lot of them are saying, we need to do this ourselves, and we work very close with organizations like Epic. And when you talk to Epic, they're like, one of the biggest demands we have is integrating technology into MyCharts where people go, so they can initiate and connect in on their own terms when they want clinical help, okay? So one of the areas this is going is that organizations are doing it themselves. They're either using their own physicians or they're outsourcing those physicians from other places for after hours, okay? And that's a very powerful model. Now, the great thing about that is they do have systems in place now, like United Healthcare with those 20 million people. When you get on and you do this, you pay your $20 copay. But guess what? If you cannot be managed over that, you don't have to go to the doctors and pay another $20 copay. They waive the copay so you can actually get the follow-up on the other side. So this is one of the biggest drivers and trends that we see. Very simple. It's just embedding video technologies. Some of it is with skill-based routing, sending people to the right place, and then basically forwarding them on. Okay? So portal-based technology is on their way. Now, my last slide is, and this is something I'm very passionate about and we talked about yesterday, in general, wellness and prevention. So I'm trying to hit on what organizations are actually doing out there to try to meet some of these population-based health things. So wellness and prevention. I think, as the gentleman said from IBM Watson, there's some really cool things we can do with analytics now. So before wellness and prevention, and this is where our healthcare system has changed. And it's not just about when we're broken, we get fixed, right? It's about how can we invest in people on the front end. And some people are going to say, well, Ron, that sounds like HMOs. That's what we've been doing for years. But let me ask you this. Any insurance payers in here? Any insurance people? Okay. So HMOs are on capitated rates, but how much did your insurance company invest in you? How much did they really invest in trying to make you healthier? I might get like an email, or I might get like something in the mail, right? Like a card or something, but it wasn't really a proactive attempt. And this is where I think that a lot of people miss. We talk about, when you talk to consumers of, like a lot of folks talked about yesterday, of accountable care, of course it impacts them directly because they're paying more for their premiums. We have larger deductibles. We have a lot of issues there. But when you look at some of the things that we're doing to help provide accountability on the healthcare side, I think some of it does make sense. But when you look at kind of three different phases, number one is how do we actually change the culture of healthcare? With my travels, there's definitely differences, right? I mean, the most obese country in the world is Mexico. In the U.S., we're like right behind them. 5% of the population of the U.S. is morbidly obese, and that's grown 4,000% since 1986. And so culturally, how do we develop sort of a healthier lifestyle and sort of culture where it makes us change? And that's a bigger issue, and that's more of a... how many of you have actually been to Brazil? Any of you been to Brazil? Right? How many have actually been to the beaches in Brazil? Right? Yeah. So like, I actually just went down there for my first time like a month ago, and I was like, okay, I'm going to go on a Friday, and I was staying on the beach, and if I say it right, Ipanema? Was that right? Okay, I always screw that up, so sorry. So I was like, oh, cool, man. I'm gonna go to the beach in Brazil. You see it. And I'm really into Brazilian jiu-jitsu, like grappling, submission grappling. So I actually got to train a little bit in the morning, and I went to the beach. And just like everyone else that goes to the beach for the first time in Brazil, my first sort of impression was, wow, like everyone was fit. It's a beach culture. Everyone was very, very fit, and then I start talking to my colleagues. I'm like, what, like, how is this, like, how do, and they're like, well, not every beach is like that in Brazil, but a lot of them are. Like, there's a culture, and it's like a beach culture, right? So there's had some cultural change. So how do we get to that? How do we move past this? But then there's kind of like where we're at now, and as we look at wellness and prevention, and so the gentleman's back from patient care from IBM Watson, which I think is interesting. The things they're doing is, we can not just look at we have predictive analytics. They can take cohorts of people and they can look at groups of people and they can say, okay, Ron, none of this is true, by the way, but man, Ron, you're 47 years old. I am 47 years old, but you drink a 12-pack a night, you smoke. If you don't do this, looking at predictive analytics, we know that 8 to 10 years down the road, this is where you're going to be. So we can start investing in those people now, so we don't actually develop those chronic diseases, which are 3.5 times to 5 times more expensive. That develop into acute diseases, which can be up to 20-fold to 25 times more expensive. So that's one thing. Predictive analytics, starting to educate people now to change behavior and identify those high-risk people. That's one piece of wellness and prevention that I think we really haven't invested as much on, but we're going to. And how are we doing that? I think what we're trying to figure out is, and some of the doctors talked about it yesterday, one of the docs talked about it yesterday, was, when do we actually utilize this technology, and when do we don't? When does it become impactful, and when does it become a burden, right? And those are some of the things that a lot of organizations are struggling with, how to change behavior. So, in short, as I wrap up here, I think when we look at collaborative healthcare, organizations are looking at meaningful ways to reach out. They're looking at different delivery systems, and we have people in this room that we say, we throw all these in corporate life and everything, we throw all these buzzwords around, care coordination, patient-centered medical care, all these things. And they're like, what, that sounds great, but you don't know my life. I'm a discharge planner, and I'm in a small rural hospital, and I have to discharge this patient. The GP lives 2 hours away. The nurse who's going to be going to the GP's house lives an hour away from them. The caretaker lives a half an hour away from them, and I'm trying to get people together, right? So how do we coordinate better and utilize technology? What we're seeing is just using even simple things, telephones, video, bringing people into group calls. How many of us are in group calls? Bringing all these different people together is very important. Anecdotal situations that are very, very basic. We're working with a hospital in Kansas. I had this thoracic pediatric surgeon come to me and he goes, Ron, he says, I need your help. I says, what? He said, we've been working with you guys for a long time. He said, we get paid in a global fee. We get paid in a global fee. He said, do you know how many times I have to keep a kid in the hospital 2 to 3 days longer than what they need to be here because the divorce rate is 50% and both parents have 50% custody? And I literally can't get both parents at the hospital at the same time to do a proper discharge. And we have to keep them because we can't do that. So we're actually using video, if one of them can't make it, to actually provide a proper discharge. And he's like, I don't know the exact number, but he goes, I know we're saving thousands of dollars. Okay? Some real basic low-hanging fruit. So if you have any questions after, more in-depth on telemedicine, let me know. But just some sort of thoughts, some of the trends we're seeing out there, a little more basic, and happy to help and work with any of your folks when we can. So thank you very much for your time.